Hello, everyone. Happy Friday. Welcome to version 1 bajillion of RLR. We're very, very excited to have you here. We've got Elena on scribing and Sohail on teaching points. I'll ask them to unmute and say hi in a second. That's because we have a guest case presenter. Luke, do you want to unmute and tell us a little bit about yourself?
Yeah, for sure. Can you guys hear me okay?
Yeah, loud and clear.
Yeah. So hi everyone. My name's Luke. I'm I guess, intern for another like 4 days, but
Woohoo!
internal medicine intern, almost done. Happy to almost be done.
Nice.
Here at Penn, I am currently in like an abandoned floor of the hospital because our workroom is under construction. So forgive me if it's weird and echoey, but yeah, excited to be here.
That sounds so cool, Luke. Thank you for sharing that. Tell us a little bit more about your journey in life. How did you end up at Penn Internal Medicine?
Yeah, I don't know. I think I was someone who I can't say why I ended up at Penn. I'm like from Pennsylvania originally,
Nice.
so I think just like coming a little closer to home was nice for sure. But I'm definitely someone who in med school listened to your guys' podcast like all the time. So I am like very excited to be here, very starstruck.
Oh,
Um, but yeah,
oh, the pleasure is all ours, especially Prof. Rez. Look at that beaming smile, those shiny teeth. He's very, very happy you're here. What do you like to do outside of medicine?
I'm someone who likes doing crosswords a lot. So
Ooh.
just re-downloaded my New York Times crossword app. That was my splurge for ending intern year. And then just like running in general, especially here around along the Schuylkill.
Oh my gosh, you and I have that in common for sure. But I couldn't solve a crossword puzzle with my life dependent on it. So I will relinquish that skill. And what about medicine? What do you think you want to do? Do you have a sense of what your future looks like?
Yeah, I'm probably interested in oncology. And like, but just generally really like, I think like hematology, oncology.
Yeah.
Um, but so we'll see. That's where I'm at now, but we'll see if things change.
Hey, I love that. I had a lot of interest in hemonc. Ultimately decided that I'd love to sort of stop the diagnosis part and move on. But that's really cool. Thank you for sharing all that. It's always exciting whenever Mark brings a friend and a colleague, and he spoke very highly of you in the chat right now. You should totally check it out. But whenever you're ready, we'll rock and roll, and we'll hear some Prof. Res wisdom for aliquot number one.
Definitely. So I can say before I start there are, I believe six aliquots, and the sixth aliquot is the final diagnosis. So for aliquot one, we have a 52-year-old male who was in his usual state of health until 4 weeks ago. And since then, he's noticed progressive shortness of breath with exertion. He is now so short of breath, he describes crawling up his stairs at home from a baseline of being able to walk completely normally multiple miles without getting short of breath. And I'll stop there.
Wow, this is a very fascinating start to the case, Luke, and very excited to have you here on RLR. Thank you for joining us, and congrats on almost being done with intern year. We have tackled shortness of breath multiple times on VMR, and we've tackled it multiple times because it's such a common chief concern. And this particular scenario is just quite dramatic that the patient is actually crawling up, that shortness of breath is so severe that they're crawling up, which is quite striking. And one thing, a point I want to make, and especially for the more junior learners in the audience, is that shortness of breath is a subjective concern, meaning you cannot tell someone they are not short of breath. On the other hand, the O2 saturation or the ABG, the chest X-ray, these are objective findings. There either is going to be an abnormality or there isn't. In someone like this, honestly, before I get any further history, I'm putting on the pulse ox. I'm already ordering the chest X-ray, and I am considering an arterial blood gas. When you're approaching shortness of breath, I think the dyspnea pyramid is a good place to start, but don't fool yourself and think just because you know that pyramid, you know how to approach shortness of breath. Because I made that mistake years ago, and that's where we say the heart, the lung, and then the other categories, which can include anemia, acidosis, thyrotoxicosis, deconditioning, test wall abnormalities, etc. So this is what I want you to do. When you think of the heart, break that down into anatomical structures, starting with the myocardium. So someone with coronary artery disease can have dyspnea on exertion that's progressive over time. If that were the case here, it would be more unstable angina, and the shortness of breath would be an equivalent of this patient's anginal symptoms. The valve, we've had multiple cases on VMR of aortic stenosis, some kind of mitral regurgitation causing shortness of breath, the pericardium, and the rhythm. When you get to the lung, just think about where air travels. It starts from the upper airway. So if someone is obstructed, they can feel short of breath. So, and in those patients, you'll actually hear stridor, but they just follow the oxygen molecule as it goes through the bronchi. The alveoli can be filled with pus, water, blood, the surrounding interstitium, the pleural space, the pulmonary vessels. That's really what you want to do. Now, what's interesting about this patient is that we can already say this is a subacute process that's progressive. I would be shocked if this were ACS or pulmonary embolism or aortic dissection. That being said, a small minority of patients will have more of a subtle onset of symptoms of these vascular catastrophes that will slowly then progress. I'm not really sure what to, how the fact that he just is so short of breath that he's like crawling up the stairs, that doesn't really affect my calculus. What I'm doing at time point 0, just getting a quick physical exam, getting some objective data to go along with the subjective data, and then just really taking an anatomical approach to this subacute worsening process. Robbie, any pearls you want to add, like from these like subtle clues of anything?
Oh, not at all, Prof. Rez. No, I think you said it so well last week about the calculus of trying to understand what the disease is, but also realizing that our insight into the disease right now on the history is through the person who is describing it. And I think unless we're collecting our own data on exam or labs, right now, I think the equally powerful variable to understanding what's going on, since this is information given from another person, is understanding that person and understanding the rationale for coming in 4 weeks into such a devastating syndrome, and understanding the rationale of crawling to go upstairs. And I think as you try to understand the words that this person is saying and their behavior, understanding it's giving you insight into the disease, but I think insight into this person is so important to really understand what this person's trying to say, and then start to build ultimately in real life, not in VMR life, to build a mental model of who this person is and how you can best help them. We talk a lot about that in the extreme when we talk about goals of care conversations for end of life, but goals of care conversations are happening even with a patient if they want a PPI or H2 blocker for their GERD at a much smaller microscopic level. And so I am so intrigued, the same point that you made last week, by how this has been going on for so long, so severe, and to crawl upstairs. I think insight into the person is going to be in real life tremendously important. And here we might not spend a lot of time on that, but that's where I'm really intrigued by, honestly. All right, Luke, tell us more.
Yeah, definitely. We were also intrigued by that same question. So for the second aliquot, he notes that he's had significantly increased lower extremity swelling during the same period of time. He also endorses some paroxysmal nocturnal dyspnea intermittently over the last few weeks. And he says that while he used to be able to see his feet, his abdomen is now so swollen that he no longer can visualize them when standing up. He says he's gaining weight, and he has a dry, non-productive cough over the same period of time. He denies any fevers, chills, rhinorrhea, or sick contacts. And he said he's tried taking some vitamin C and Theraflu for the cough with no resolution. And finally, he says that over the same period of time, he's been having dark urine without dysuria. And then I'll add just for his medical history, he really has no known medical history, but notes that he's uninsured because he works odd jobs, so hasn't seen a doctor in, I think, over a decade. takes no medications, no significant family history. And then he lives in Philadelphia and has had no recent travel, doesn't drink alcohol, no history or current use of substances, and he's not sexually active. I'll stop there.
Oh, Professor, maybe I'll just pontificate about all this data because I think it's building towards a specific case, and then you can layer on what I've missed. And I'll tell you that I was all on the heart failure train until you said something that made me pause and calibrate just a little bit, but not reverse my instinct. And I think that's, somebody saying that they're short of breath, and then you have evidence of volume overload by evidence of lower extremity edema and abdominal swelling immediately. Immediately start to say, okay, this is a volume overload state, and the volume overload is causing shortness of breath. And so we know that there are 3 common volume overload states. It's namely heart disease, liver disease, and kidney disease. And when somebody is presenting with shortness of breath, I think we tend to prioritize cardiac diseases. And so the question is there anything that moves us beyond that? And I think the answer is maybe a little bit, and that's the dark urine. In the vast majority of cases, dark urine is actually purely noise, and it represents concentration of urine as a result of reduced PO intake or reduced renal perfusion. And so his dark urine may simply be just concentrated regular urine, but at the same time, you have to wonder, is his urine dark because of something that's not supposed to be there, instead of the usual things in just more concentrated form? And immediately in the setting of volume overloaded, mapping them onto the pre-existing organs, the heart, liver, and kidney, you wonder about the presence of direct hyperbilirubinemia, and that being the potential cause of his dark urine. We, of course, haven't looked at his eyes, but if his eyes aren't yellow, then that hypothesis becomes dismissed immediately, because it is impossible to have bilirubin in the urine so much so that you can see it without having it deposited in the sclera and the conjunctiva. You may wonder, well, he's not reporting yellowness in his eyes. Does that dissuade you in any way, shape, or form? And I think I've seen many patients not notice that, and family members notice it, or us noticing it at first insight. So for me, I think this aliquot is really, Reza said heart and lung for dyspnea, and I think that with that calculus alone, you throw in the volume overload, and you get to heart, period. But I think the presence of dark urine, especially if volunteered spontaneously by the patient, meaning that it is prominent to him rather than actively recruited and drawn out on review of systems, may be signal towards pivoting to something else, which then leaves the question, well, why would the patient be short of breath? And the patient might be short of breath because of the compressive effects of ascites on the diaphragm, causing orthopnea and causing dyspnea. So I think for me, what am I most intrigued by? I'm most intrigued by the fact that this is probably going to be heart failure, but the history sprinkled in a little bit to have my toes up to make sure I don't commit to the wrong organ. But I am not too worried about committing to the wrong organ because I think that the exam will be really, really telling. Scleroicterus will be telling, and a JVP will be telling, with the JVP being very unusual in most patients with liver disease. I think any time that you're trying to say which one is it, you should stop and make sure that the patient doesn't have a bit of both. And Prof. Reza and I just got great news yesterday that a case that he was involved in real life, which featured liver and kidney, just got accepted for publication. So that was yet another reminder of volume overload states occurring from multiple simultaneous organs. So that's what my reflex response was. I was heart until you threw that dark urine in. I'm curious, what was your thinking, Prof. Reza, and where are you at now?
When you talk about our paper, and I thought you were going to say that was a great reminder. That was a reminder of how great we are that it got accepted. Thank goodness for the Federal Practitioner Journal. Impact factor may be low, but it's indexed and it represents the veterans. So don't judge us. Robbie, you know what's so interesting about this aliquot? When we do these cases, we want to try to simulate real life as much as possible. And here we're really focused on analyzing more so than acquisition of data. But I'm always a little cautious with terms like paroxysmal nocturnal dyspnea. Because if orthopnea is not specific to the heart. One of the Reza brothers made the most phenomenal orthogonal schema with Rabih, but paroxysmal nocturnal dyspnea is much more specific to the heart. And why is that? Paroxysmal nocturnal dyspnea is literally when you take away gravity, fluid from that interstitial space goes intravascular. So now you're almost giving fluid to the heart. And so if you're in heart failure, you can't pump that blood forward. Now you're feeling dyspneic. So what is paroxysmal nocturnal dyspnea? It's literally the patient goes to sleep, wakes up, gets to the edge of their bed, and that's paroxysmal nocturnal dyspnea. So I'm always a little cautious labeling it. It's not just shortness of breath at night, because that can just be orthopnea. Furthermore, someone, if they're aspirating or they have GERD, can develop shortness of breath at night. PND usually takes several hours to develop. It's not immediate like aspiration. It's not as quick as GERD. It's a little delayed. All that is to say, if this is truly PND, it really prioritizes the heart. And then with regard to the dark urine, I just wanted to piggyback off what you said. When dark urine is caused by a bilirubin pigment, it's direct bilirubin, because that's can actually travel through the blood and get into the urine. Indirect is water insoluble, so it's not a marker of hemolysis, rather compression of that biliary system or the hepatic, cells. On the other hand, you can have hemolysis in dark urine, but it's hemoglobinuria, and that's when you have an intravascular hemolysis, and then the urine turns dark. So Rabih, if PND is PND here, I'm inclined to prioritize, and I think you are too, the heart over any other organ. And then I would say the concentrated urine is because you have decreased effective arterial blood volume, stimulating vasopressin secretion, causing concentration, which is what you had said as like the most common cause. But back to you, my friend. Luke.
Amazing. So I can give you some of the things that you asked for. In terms of vitals, he is afebrile. His blood pressure is 203/91. His heart rate is 121 beats per minute. Respiratory rate 20, and satting 98% on room air. For his exam, he's well appearing, speaking in full sentences on room air. He has very icteric sclera and sublingual yellowing. He has mild crackles at the bases bilaterally. For cardiac exam, regular rate and rhythm, no JVD that we could appreciate. And then his abdomen is very protuberant, but soft. He has 4+ pretibial pitting edema in his legs, and some in his arms, and some in his chest wall. He otherwise has no joint swelling or tenderness, and he has no rashes. And I'll give you a few labs here as well. So his white count is mildly elevated at 13 with a normal diff. His hemoglobin is 8.3 with an MCV of 96. His platelets are slightly elevated at 550. His creatinine is 1.2 with no baseline. His AST is 51, ALT 40, and ALK phos 143. His T-billy is 14, and his D-billy is 5. His INR is 1.5, and a BNP is greater than 6,000. And I'll stop there for now.
Wow, this is phenomenal stuff, Luke. A lot of interesting things. And this is what I want to share with you guys. I'm going to share this screen. And we made this figure with Carolyn from MGH when she was a resident. And this is where we're approaching dark urine. And what you can see here, like the most common causes is hypovolemia, meds, and hematuria. And the first approach is like, we're not dealing with an exogenous pigment. And then when you come into endogenous pigment, basically you get a UA. And here, if it's negative, then you're looking at hypovolemia, direct bilirubin. But if it's positive, then you can see if there's RBCs or positive RBCs or negative. So why am I showing you this figure? Because the point I'm trying to make here is that if the bilirubin is the cause of the dark urine, it's direct, because indirect is not soluble in water and shouldn't get to the kidneys. So I'm going to stop share this, and then we'll actually analyze the data that was presented. If we can get the whiteboard back up. Thank you. So I'll just share my preliminary thoughts, and then Ari, please layer on to anything that you want. I think when you're approaching a case like this, it's really important to go and look back at the past medical history. And there you see that he hasn't had care. So the lack of any past medical history doesn't mean the absence of any medical illnesses. And so that's why I'm looking at this individual's blood pressure. It's quite elevated. But I don't really think hypertension is the problem we're solving. I think the hypertension may be something that's long-standing. And how can we find evidence for that? Well, you can look at the EKG to see if there's LDH. You can look at an echocardiogram to see if there's thickening of the left ventricular, if there's left ventricular hypertrophy. Those are some surrogate clues to how long-standing the blood pressure is. But what I can tell you is when you have real high blood pressure, it's best to either label it as symptomatic or asymptomatic. Now, this guy is really short of breath. But his O2 sat is 98% and his crackles are only mild. So it's hard for me to blame the heart and the blood pressure as the primary abnormality leading to his dyspnea, because there's just a disconnect between the degree of shortness of breath and the oxygen saturation. When you have liver pathology, and as Rabih was mentioning earlier with regard to ascites, that's more in the context of portal hypertension that may be from cirrhosis. And in that context, the ascites can affect the diaphragm contraction and give you that sensation of shortness of breath, or you can develop hepatohydrothorax, and now you can have a pleural effusion that can cause atelectasis, crackles, and shortness of breath. But if you analyze this patient's hyperbilirubinemia, it is primarily indirect. And a general pearl about hemolysis is that when you have indirect hyperbilirubinemia from hemolysis, it usually doesn't exceed 6. It usually does not exceed 6. But whenever you, in this individual with this indirect hyperbilirubinemia, coupled with the anemia, hemolysis is the most concerning finding. And then you see that the AST is also higher than the ALT, giving additional strength to that hypothesis of hemolysis. But I can't just blame the degree of hyperbilirubinemia on hemolysis alone. So I think you actually have a combined direct and indirect. And I would be concerned about portal hypertension and this individual's liver function. But what I take from this aliquot of information is something else, is that with hemolysis alone, it would be hard to explain the 4+ kidney edema. You could have anemia leading to high output heart failure, but not at levels of 8. It seems like it would be a little too extreme. So that's another reason to actually try to separate these problems and then later see how you can explain them together, meaning I would have hemolysis on one side, and then I would have the edema on the other side. The lack of JBP elevation takes the heart off the table if you're good at the physical exam. But I would certainly get a urinalysis to see if the kidneys might be on the line. Could you have kidneys and hemolysis, and then we can look for their overlap? But I would also be curious to the function of the liver. The INR is slightly elevated, but that platelet of 550 makes liver like cirrhosis less likely. But you still have to explain this edema. There's no murmur. I just don't think it can all be explained by the anemia. But very quickly, to talk about hemolysis, you'll send an LDH on this patient, you'll send a haptoglobin, you'll send a retic, and you'll get a peripheral blood smear. And then you'll be wondering, are you dealing with something intrinsic to the red blood smear and to the red blood cell, like something on the membrane, hereditary spherocytosis, something within the red blood cell, like an enzyme deficiency, G6PD deficiency, or a hemoglobinopathy like sickle cell, or you're dealing with something extrinsic to the red blood cell, and that's environment, like a MAHA or an autoimmune hemolytic anemia or some kind of infection. Most commonly in the United States, it would be cachexia. But there's a lot to unpack here. So I'm going to give the mic to Robbie, and I just want to conclude by saying middle-aged man, subacute progressive shortness of breath, hyperbilirubinemia, primarily indirect, strong clues for hemolysis, but you have another element of edema that needs further explanation with the normal JVP. A lot going on, Robbie.
I love that summary, Prof. Rez. A lot. Honestly, I think that I'm a little bit stretched thin about where to go. And I completely agree with you that we have to exonerate hemolysis. The heart's maybe on the hook because the BNP is high, but the JVP is not. The kidneys may be on the hook because the patient has anasarca and we don't yet have a serum albumin. The liver's definitely on the hook, but is it on the hook fully or is it mostly indirect? It's really hard to analyze this with confidence, but if I'm being honest, I think the thing that I have a hard time skipping over are the combination of the hypertension and the tachycardia. And I think that we don't really know if the tachycardia is sinus or not, but we assume that based on the fact that he's regular and that he is stable, that he's not in, he's regular, so he's not in AFib, and he's stable, so he's not in VTach, that I think I'm inclined to think this is sinus tachycardia. And if you step back and you ask yourself, why would somebody be in sinus tach? The reason to be in sinus tach that would make sense physiologically is that you have current or impending hypotension. And that's not at all the circumstance that this patient is in. In fact, he is markedly hypertensive. And to complicate things further, he's hypertensive in a way that is extreme. Look at that pulse pressure. He's got a massive pulse pressure. And so I'm really, really intrigued by that. And it just makes me a little bit unsure if the ground that we're standing on is one in which we've made assumptions. And I definitely made an assumption that now I'm undoing, which is believing that this syndrome is definitely 4 weeks old. And the evidence for that is just how sick this person is, the complicated narrative in the HPI, and then also the fact that he hasn't seen a physician for a long period of time. And so I'm wondering now if really, is this if this is a subacute presentation, or is this story much longer than that? It's just hard to imagine that you can get to a blood pressure that high and have an O2 sat like that without it being full of pulmonary edema in a patient who's already decompensated this way. But I think if we step back from that and say, okay, I have the combination of tachycardia and hypertension, what can I conclude? I think you can conclude that this patient has, especially if it's sinus, that has much higher sympathetic tone than they need, because their heart rate should only be high if their sympathetic tone is needed to compensate for current or impending hypotension. So I'm running my mental DDX for excessive sympathetic tone. And the most common cause in all comers is there's excessive sympathetic tone because the patient is taking something or withdrawing from something, an exogenous cause. There are, however, some endogenous causes. The most esoteric and cool is a pheochromocytoma, which is not compatible with this case. But I think the most important endogenous cause is hyperthyroidism. And so I'm sitting here wondering, thinking, hey, could this be hyperthyroidism? And I say that because of the vital signs alone, but then when you match that with the fact that he has a predominantly indirect hyperbilirubinemia, has heart failure with the BNP, has liver failure, I would say it is so easy to forget to get a TSH up front in this patient. And I hope it's normal, but I would definitely be really worried about it. Similarly, another really high yield test will be a serum albumin and a UA, because this could easily be that the kidney is on the hook for the marked hypertension and the patient is tachycardic because they're relatively volume depleted. And that can happen in patients with nephrotic syndrome who are so anasarchic and have so much loss of interstitial fluid that they leak fluid into their interstitium and have hypertension from RAS and have tachycardia from intravascular hypovolemia. So I honestly, I'm a little bit too wobbly to plot out a clear pathway forward. And I think I'm on guard. I know the heart's, at least something is wrong with the heart because the BNP is too high for it to be otherwise. Something's obviously wrong with the liver. The question is there superimposed hematological issues with the indirect hyperbilirubinemia? I want to make sure we don't overlook the kidney, as Prof. Rez said, with a UA and a serum albumin. And I think all those organs may be on the hook, or there may be a systemic disease like hyperthyroidism that's pinging off all these organs that unite them. So anytime you see these vital sign abnormalities, I think it's really important to get a UTOX to make sure that the patient doesn't have a substance causing them or withdrawing from them, and to get a TSH. My final piece of advice is around oh, what was that? I lost my train of thought. Never mind. It might come to me later. I had one more piece of advice, which clearly isn't that important because I forgot it. But yeah, I'll pass the mic to you, Luke, for more information.
Yeah, absolutely. I'm glad it was not just Mark and I who were struggling or like very confused by this patient. I can add some more labs that hopefully will help a little bit here. So his hemolysis labs were like the textbook for hemolyzing. His haptoglobin was undetectable. His absolute retic was 330,000, and his LDH was elevated at 500. He had a positive direct like IgG Coombs test as well. And then for his fibrinogen was not depleted, so like normal at 316. And his INR improved from 1.5 to 1.2 after some vitamin K. His UPCR was like borderline above the like limit of normal. So we got a 24-hour collection, which was essentially showed no proteinuria. And his serum albumin was 3.5, but essentially normal. His UA had no RBCs on the urine micro. A TSH was normal and a UDS was negative. By the way, I forgot, it was sinus tachycardia. And then I'll add he had a chest x-ray done, which showed diffuse interstitial and multifocal airspace opacities that they read most likely as pulmonary edema. But given everything going on with him, we obtained kind of a pan scan just to see better his liver and his lungs. So a CT with contrast of his chest showed multifocal nodular foci of ground glass and consolidated of opacities throughout the lungs, favored to represent pneumonia, with a small right and traced left pleural effusion. His CT abdomen pelvis showed hepatomegaly with a heterogeneous appearing liver, but no evidence of bile duct dilation. And then he had a TTE done as well, which showed a normal EF at 55%, moderately elevated PASP, and a dilated IVC. A couple other labs, just to note, he had an RVP that was negative, his HIV was negative, and he had blood cultures that ultimately showed no growth. So he was started on coverage for CAP, got some diuresis, and was admitted to our service.
Wow, absolutely fascinating. I'll just kind of, I think Prof. Rez, you were on the hemolysis train, so I'll leave that for you to analyze and just say that I think the progress that we made in terms
Can
of.
I just make an interjection? But that's already been analyzed. The Coombs is positive.
Well, through that.
I'll analyze it more.
Okay, you'll analyze it even more. Yeah, I think that the progress we made is that I think we have exonerated the kidney with the normal proteinuria and then relatively normal serum albumin. And so I think that the kidney dimension is probably not something very prominent for us to really focus on. The liver dimension is questionable, I think, because we obviously have direct hyperbilirubinemia. The indirect is now fully in Prof. Rez's hemolysis category. The two evidence points for liver involvement are the direct hyperbilirubinemia and the fact that there's hepatomegaly. And I think the active question that I'm wondering about, in the absence of any reasons for liver disease that have made it apparent so far, no hepatitis, no alcohol, is the liver involvement as a result of backflow from the heart, given the fact that the IVC is now dilated for sure. And so I think the question that we're grappling with is this a heart failure syndrome alone? This is a hemolytic syndrome with heart failure alone, or is there additional hepatic involvement as a clue? And then the parallel question is, with the lungs, is the lungs also a separate entity with the consolidations, or is that also as a result of the cardiac manifestations that are going on? So it's going to be interesting to try to see if we can pull out liver and lung as separate disease categories to factor in which the core issue, which is hemolysis, or are they all sequelae of the heart? So in other words, is our problem representation a subacute heart syndrome with a hemolytic anemia, or is it a subacute heart syndrome with liver disease and lung disease, or is it a subacute heart hemolytic syndrome with lung or liver? And I think if I were to be trying to figure this out in real life, I think I would try to keep it as simple as possible to see hemolysis plus heart and what progress that allows my brain to do, because I don't think I'd be able to handle the cognitive load of lung and liver as well. And that's probably what I would do. But I'm curious where you're at, Prof. Reza, and what you're making of the hemolysis labs.
Thank you, Robbie. Luke, can I ask you a question? What did the smear show? Did it show anything?
My understanding is it was essentially just schistocytes.
Schistocytes, okay. This is a really tough case, Robbie. And I'm not mistaken, I think the Coombs was positive, right? So the Coombs was positive, and we'll tackle the schistocytes in a second, but Robbie, what I'm thinking is that when you have an autoimmune hemolytic anemia, the first question becomes, is it warm or cold? And then the next question becomes, is it primary or secondary?
I want to interrupt. Mark texted me a correction that it was spherocytes and not schistocytes. That is my fault. Okay. So before I send you down that path.
Oh, thank you, Luke. Listen, I deserve to be sent down that path because you just have to go listen to our episode. Sometimes I don't even give Robbie the right chief concern. One time he was solving the problem of coldness on exertion. I forgot to include the angina on exertion, but anyways. So Robbie, like, the spherocytes are consistent with autoimmune hemolytic anemia. And when we approach autoimmune hemolytic anemia, the question becomes, is it primary or secondary? I think you would agree that in a case like this, it's secondary. It's not, this isn't your classic, like, oh, the patient has a primary autoimmune hemolytic anemia, with just anemia as a focus, as a center. There's so much going on in this case that I almost feel like the autoimmune hemolytic anemia is just another marker of whatever systemic process is unfolding in this patient. Let me pause there to see what your thoughts are on that before I continue.
Yeah, Professor, I think if we just keep it simple and say heart hemolysis, I think that it's, as you said very early on, a high output state from a hemolytic anemia is very possible, especially with those vital signs. I mean, those vital signs are very high output heart failure, and also the echo with a high PASP, which may be as a result of increased pulmonary resistance, but equally likely as a result of increased pulmonary flow, increasing the pressure. So I think the connection of hemolysis and heart failure could be that the anemia is causing high output heart failure, or that there's an underlying issue. When I start to think of underlying issues, I can't think of anything very quickly that causes hemolytic anemia and heart failure in a classical way. But that may be just that I need more time to do that. Yeah.
And so I think what I honestly was doing, and I'm going to share this screen because this is like how I work in the hospital, and I want to mimic what I do exactly in the hospital for all of you. I'm going to share this incredible figure that Robbie created, and we diagnose autoimmune hemolytic anemia, and you can actually make more progress and say, is it warm or is it cold? And we have spirocytes, and I think we're looking at these secondary causes. Like, is there some kind of lymphoproliferative disease, and were those interstitial markings representative of, like, I don't know, like a lymphoma or lymphoma-like process within the interstitium? I really was like gunning towards something like a tafril, a lymphoma, Castleman, but then you look at the platelet count, and the platelet count's 550,000. It's elevated. It's not low. It's not a good story for lupus, and there's no obvious infection. And so the question is, are we missing a drug exposure, or are we missing an underlying lymphoproliferative state, I actually don't know what my next steps would be. I think if the entire story was just autoimmune hemolytic anemia causing a high output heart failure, I guess maybe it is possible if the delta was so quick. You know, you go from normal hemoglobin to an abnormal hemoglobin. And if that were the case, then the center of gravity would be autoimmune hemolytic anemia. And at the end of the day, the final diagnosis has to explain that. So the question is, where do we go from here? We review the drugs, any exposure that could potentially link this. And maybe if that's negative, you could do a PET CT or something looking for malignancy. But let me throw it back to you, Rob, before we go to Luke, because I'm actually curious. Like, I don't know what I would do. I mean, at this stage.
You know, I think, Brofers, we talk a lot about like indications for transfusion, and we talk a lot about acute blood loss, and talk a lot about the hemoglobin threshold. But I think symptomatic anemia also comes into the calculus. And I think here I'd make the argument to try to see what this patient's heart failure does with blood transfusion. Because I think if you give him a couple of units of blood and you watch that heart rate come down and that blood pressure relax a little bit, you might make a lot of progress. And actually find connect, because you're trying to draw the arrows, right? Is the anemia causing the heart failure? And then you also might consider in this patient, the one of the few patients who you might do a right heart cath and actually measure his filling pressures and his cardiac output to really understand what the nature of his heart failure is. Because I agree with you. I think we know what the nature of his hemolytic anemia is, and I think we're trying to figure out, is it primary or secondary? I think we have yet to fully clarify what the nature of his heart failure is beyond the label of HFpEF. And is this HFpEF as a result of high output or not? I think will allow us to make a lot of progress. Because if we can say this is a hemolytic anemia with, for sure, high output heart failure, I think we can make a lot of progress. So I'd be curious if people would be inclined to give him blood to see how that helps his vitals. And I think I would wonder about a right heart cath to measure his filling pressures. What do you think?
Oh my gosh. So in talking with you, I think maybe if everything is explained by this hemolytic process, then we can anchor on primary autoimmune hemolytic. And you might say, well, why is it so severe and aggressive in its manifestation? Well, it's been going on for 4 weeks. It's been going on for 4 weeks, and now you're seeing the end stage of likely. And I like this hypothesis so much, Robbie, because the secondary causes, I just don't see a good fit. There's nothing striking for lymphoma. There's no drug exposure. And so now all of a sudden you're thinking, okay, you have abnormal immunoglobulins. How can you actually approach this? You could start considering prednisone and suppressing immunoglobulin synthesis. You can consider rituximab. You could consider plaques. So I think, Robbie, in talking with you, my conclusion is there's no strong hit for secondary. We have to explain the autoimmune. Let's just treat this as primary and see what happens. And if it doesn't get better, then we reconsider a secondary process. I love that.
All right, Luke, I think this is aliquot number 5, huh?
Yes, we are here. This is my laundry list aliquot, so I apologize in advance. I will try and give you some of the things you asked for. To go through some labs for him, his ferritin was elevated at 340. He had both a mycoplasma and a urine chlamydia and gonorrhea, which were negative in the setting of the opacities. A G6PD was done, which was normal. A CK was done, which was normal. An ANA was sent, which was 1 to 320. An SPEP was done, which showed no evidence of a paraprotein. He had light chain scents in his urine, which were also normal. He had normal quant immunoglobulins, and an IgG4 panel was negative. For his acute hepatitis panel, that was also negative. A ceruloplasmin was sent. Basically, all the hepatitis labs were sent, which were all normal, including ceruloplasmin, AMA, and anti-smooth muscle antibody. He had an A1C sent, which was 8, and some mildly elevated LDL on a lipid panel. And then we kind of were going through the same thing, but ultimately ended up getting vessel imaging on him to see if he was hiding like an SVC thrombus or a clot somewhere else, which was negative. He didn't have a clot in his SVC and his portal veins, and Dopplers of his lower extremities were normal. And then re-reviewing the imaging of his CT chest, they did find some like axillary lymphadenopathy. And ultimately the decision was made to biopsy one of the lymph nodes, then start him on steroids. He got, instead of blood, they diuresed him to see if it would improve his heart rate, which it did. His heart rate came back like down significantly with an extreme amount of like TID diuresis. And I guess I'll stop there before I talk about like the lymph node biopsy. But yeah, I'll pause there.
Robbie, I'll just say a few words and then pass the mic to you, Naka. I think that this case is so fascinating. It's so fascinating because we have anasarca, we have lymphadenopathy, we have probably warm autoimmune hemolytic anemia. Now I think there's strong reason to believe this is a secondary process. You know, prior to that lymphadenopathy, but you know, I think it's secondary. And the part that is these lymphadenopathy, you start wondering about infectious mononucleosis from HIV, EBV, CMV. You worry about syphilis, you worry about lupus. I would send an RPR, I would get an HIV, I would send the EBV, the CMV. But then ultimately, you wonder, is this a lymphoma? And that would be wild, just with that platelet. I know we've seen it in the past, the platelet was normal and we still have lymphoma, but lymphoma would be such a good fit for secondary autoimmune hemolytic anemia. But I think at the end of the day, you excise that lymph node or you get a core biopsy and see is it lymphoma or a lymphoma-like process. And then, but I want to say that the CT of the chest, if those markings was pulmonary edema, that would be explained by the heart. If it weren't, then you do have to like broaden to include lymphoma-like Castleman's and such. But I don't know. I would love for you to share your thoughts, Robbie, but also just can you comment on the platelets and help me? Like, how would you analyze them in the context of like what we're making of?
You know, Prof. Rez, I think I'm right there with you. I feel like my analysis for the next this aliquot begins with taking the ANA of 1 to 320 very seriously. Not only because it's so high, but because this is also a man. And so that ANA is signal. And I think it would be erroneous to say, oh, this person therefore has to have an autoimmune disease. I think that's when you just have to realize that this person's immune system is appropriately triggered. And the question is, does this person have lupus, scleroderma, or mixed connective tissue disease? Those are the three ANA positive diseases, SLE, scleroderma, MCTD. And the answer is there's not much compatibility with those three diseases. The patient doesn't have proteinuria, doesn't have hematuria, doesn't have a malar rash, doesn't have arthritis. And so that's where you like, what else triggers an ANA? And I think that's where you were thinking lymphoma. And for me, I think that's the diagnosis that is probably most likely as a lymphoma causing a hemolytic, an autoimmune hemolytic anemia. And it was literally on the schema that you pulled up, and we weren't thinking about lymphoma because we didn't have any lymph nodes at all. But the question is, what does the thrombocytosis do for me? It has me lean in harder than I would otherwise to the lymphoma-like diseases, and has me lean harder to Castleman's, specifically multicentric Castleman's, because of the anasarca. And if you say anasarca plus thrombocytosis plus lymphoma-like disease, I think you start to be suspicious of Castleman's. And I think the reason to be more suspicious of that than just the base rate is how hard it is to diagnose Castleman's on lymph node biopsy. It's just as tough as it's just as tough as trying to find Hodgkin cells. You really need a very experienced histopathologist to diagnose this disease. It's very, very subtle. So I think base rate would suggest lymphoma, but the thrombocytosis, which would be a little bit unusual for lymphoma, and then the presentation of anasarca out of proportion to anything else would have me worry about that possibility too. there's this, I'm like trying to replay the case in my mind. It is such a fascinating series of events and trying to pick out a hemolytic anemia amongst a storm of organ. Like, I can't wait to reflect on it. But I do think that the lymph nodes probably host the answer, because everything else is just seems a consequence. The hemolytic anemia, what's that? What's the underlying issue? The heart, what's the underlying issue? And I think the lymph nodes would probably answer it. Thoughts on that, Prof. Rez, before we have Luke tell us the answer?
My only thought, it's like always such a privilege discussing with you, and like your reflexive frameworks, and like I overlook the ANA, but it's great to approach it like that. And the thrombocytosis, that would be such a pearl to prioritize capsule meds. But we'll see what Luke says. Watch him say there's a drug. The patient was taking a drug unbeknownst to us.
So this is the part where I have to confess that Mark and I are kind of using this a little bit because no one's quite sure what's going on with this patient still. So I can tell you a couple of things I don't want to forget, but let me read. So the biopsy report, basically what it called was an atypical lymphoid infiltrate. And then the hematologist, who we just saw again yesterday, essentially said it's neither normal nor revealing. So it does not rule out malignancy, but it's also not a slam dunk, kind of as you guys were referring to. He was started on like a high dose of steroids. He's still on 80 milligrams of prednisone just to treat the hemolytic anemia. And EBV was negative. Sorry, an IgM EBV was negative and an IgG EBV was positive. And then the peripheral flow was normal as well. So we kind of were left with the same question, which is essentially like, is this a guy who ultimately ended up getting diuresed like 100 pounds in the hospital, who had severe HFpEF and happened to have hemolytic anemia at the same time? Or does he have some like underlying either autoimmune or lymphoproliferative process? And I think even from the hematologist note yesterday, no one's still quite sure. Their plan is essentially to try and like treat him through the hemolytic anemia and then re-image off steroids once it gets better, but we really do not know. And I apologize because that if I'm very frustrated by it ourselves, but this has been very helpful for us to kind of hear like your guys' thoughts for sure.
I just want to say, Luke, I love this case for so many reasons. It just like really mimics what we experience in real life as clinicians. Sometimes we don't arrive at a diagnosis in the moment. And I'll just say this, as long as the patient's getting better, you just have to track and see what happens. And it's so cool to see that we sort of ended up in the same place, because at 1 hour apart, we're like, just treat the, you have to understand too, when we're solving, we're thinking that you do have a final diagnosis, so we're putting our money down. But in reality, we would say like, oh, are those lymph nodes just there? And they're not representative of anything. So I just think that you guys did a stellar job. This highlights what we experience every day in medicine. And that, yeah, just, Robbie, I want to just give the mic to you. Like, I think that hypothesis is this primary autoimmune all along. And, the patient will just get better and you just suppress that. And it's fascinating. Man. Wow.
I am just so intrigued, and I think that the answer to this case is the most real life answer that we'll get. And most of the time, it's hard to wrap things up in a neat bow. And I think the amount of learning that we got to do is unbelievable. I think to sniff out hemolytic anemia like you did, Prof. Rez, when anemia of chronic inflammation is so common, and to not just lock into that when there was anemia and indirect bilirubin was such a key learning point for everybody, I think myself included. And then I think the ongoing dilemma and the challenges of the non-specific label of HFpEF, like what does that really mean? Does that mean pericardial disease? Does that mean infiltrative disease? Does that mean high output? That's always very tricky, and that in his future, that could be a route to clarify what he has or had. And I think another route is to question the nature of the lymph node biopsy. I must have missed, was it a fine FNA or core or an excisional? And I think I imagine those two pathways might help you elucidate going forward. But at the end of the day, I think common things are very common. Patients have half of idiopathic reasons all the time, and 50% of warm autoimmune hemolytic anemia, 50% is idiopathic. So it could just be two diseases collided at the same time. And I bet you that overall statistically is much more common than the disease being unified by something underneath. And the quest for something unifying underneath is probably going to be driven by how the patient evolves. And if he evolves in a reassuring way, you would never look back and question anything. If he revolves in a non-reassuring way, you'd look back and you'd be like, oh, thrombocytosis, oh, positive ANA, oh. But you may never say oh again. And we'll see. I hope for him that you'll never say oh again. But there are a lot of intriguing threads that are not fully tucked in, but oftentimes they're not, and that's the reality of medicine. I'm curious what your reflections are, Luke, like what you anticipate going forward. Yeah, just wanted to get your thoughts on that too.
I can definitely give my reflections, and then Mark, if you have anything to add, please, because Mark was my guide on this case for many weeks. So we're excited to discuss it for sure. I think, yeah, I totally agree. I forgot to add, but he felt significantly better after the diuresis. Like this man went from not crawling up the stairs to pretty much back to his baseline after losing 100 pounds, which I think we also were really reassured by. It is interesting that it looks like, based on his labs from his appointment 2 days ago, he is still hemolyzing significantly on 80 milligrams of prednisone. So I wonder if this is the point where they're going to start to consider rituximab, like they're mentioning, or if they are like, our hands being forced here, and we can't keep someone on 80 of pred for a while. But overall, yeah, I think this is just such an exciting case to kind of figure out, like, is it two things at once? Is one causing the other? And we still really just don't know.
So intriguing. Just for the group, because I think it's an open question in the chat. Do you mind reminding us how the lymph node biopsy was obtained? Do you remember?
Yeah, sorry about that. It was an excisional lymph node biopsy.
Okay,
Yeah.
all right. So you got the whole thing. Okay, that's
Yeah.
very intriguing. Okay, all right. Well, hey Luke, I will remember this day and this discussion for a long time. This was a very, very memorable case. And I think the lack of a clear answer really allows us to look back and try to see if we can extract one with more clarity from reanalyzing the data. So I'll be spending a lot of time this weekend thinking about this case and seeing if I come up with anything. I often don't, but I'm excited to learn along the way. But for more learning, I'll pass the mic to Sohail to share with us your teaching points.
Thank you, Luke, so much for the great case. And thank you, Rabih and Reza, for your discussion here. So some of the teaching points. So we first started the case with shortness of breath, which was the initial chief complaint. Subjective or shortness of breath is a subjective concern. You can't really tell someone if they're short of breath. So the patient has the greatest insight into SOB. Objectively, we can measure shortness of breath through an O2 sat. And the next first step would be to order a chest x-ray, ABG, and a pulse ox to better characterize shortness of breath. The dyspnea pyramid is something that is really emphasized on the clinical problem solvers. It's a great start, but we need to break it down further into anatomical structures. So for example, for the heart, the myocardium, valve, etc., and for the lung, the airways. ACS, pulmonary embolism, and shock would be uncommon with this patient presentation, but a small minority of patients can present subacutely. The next teaching point is the lower extremity swelling and the volume overload status, which all can lead to shortness of breath. There are three etiologies: heart, liver, and kidney to consider. However, the dark urine is a separate sort of related etiology, and dark urine can be purely noise, but most of the time, concentrated urine is due to RAS activation and dehydration. Dark urine can also be due to presence of direct hyperbilirubinemia, and direct because that's the type that's soluble, and so can seep into the urine. The next step would be to do a thorough physical exam to look at other structures such as the sclera and the conjunctiva, and patients may not notice jaundice in their eyes. Shortness of breath can cause or can be due to a compressive nature of ascites on the diaphragm. So also consider the volume overload status next to the liver. Caution with terms such as paroxysmal nocturnal dyspnea, because these are terms specific to the heart. And the true definition of this term is when patient wakes up from sleep, they're short of breath, and then they get to the edge of the bed, and then the dyspnea is relieved due to decreased venous return to the heart. We looked at a schema for dark urine, the most common etiologies being dehydration, medications, and hematuria. Can further be broken down into heme positive versus heme negative. What is unusual in this patient presentation was the blood pressure and heart rate being both elevated. And usually the heart rate is elevated due to an impending hypotension. But in this patient, there's no evidence of hypotension. And so the most probably cause is excessive sympathetic tone due to exogenous cause being the most common cause, but need to also consider endogenous causes such as the thyroid gland. Shortness of breath, and the relatively normal O2 sat and the normal respiratory rate sways us away from the heart, but you cannot ignore the high BNP here. If we are to consider liver pathology, it can lead to portal hypertension causing diaphragmatic compression. There's primarily indirect hyperbilirubinemia in this patient, though indirect usually does not exceed 6. Hemolysis cannot explain the 4+ pitting edema in this patient, so need to obtain more labs. So then we were considering whether this was hemolytic syndrome with heart failure alone, or whether there was additional hepatic involvement. How do we fit the pulmonary pathology in this clinical picture? We got results of the peripheral blood smear being spherocytes, which is consistent with autoimmune hemolytic anemia, which can be due to primary or secondary causes. Then we were considering that maybe the heart failure is high output, especially due to the high pulse pressure, and the anemia being the primary driver of the high output heart failure. But we needed to do more studies on the heart failure, or possibly maybe even transfuse blood to see if the anemia or if the heart failure resolves with treating the anemia. Finally, we got a high ANA titer, which the 3 most common autoimmune etiologies are lupus, scleroderma, and mixed connective tissue disease. But the patient does not have kidney disease, and in fact has anasarca that's out of proportion to kidney disease. And so most likely cause is secondary due to lymphoma, particularly Castleman's disease, due to both the anasarca and the axillary lymphadenopathy. And also keep in mind that 50% of AHA is idiopathic, so these may all be separate conditions. And in the end, sometimes we do not arrive at a diagnosis, but our goal is to make the patient better, and that's really the ultimate job here. Thank you very much.
Robbie, you're muted. Maybe we'll learn after another pandemic.
Clearly, I don't have the wisdom that Soho just shared. That was awesome. So thank you for emphasizing the final and most important point, but also not underemphasizing all the bread and butter learning that Prof. Rez shared. That was really beautiful. And yes, I will eventually learn how to unmute maybe someday. Thank you, Prof. Rez. Thank you, Luke. Thank you, Elena, for scribing such a rich case. And again, thanks again, Sohail, for an awesome job with the teaching points. See you guys later.